When I talk to patients about the treatment options for lung cancer, in broad strokes, I think of three different categories. There is chemotherapy that came out really in the 60s, 70s, and 80s, and we've continued to refine. And chemotherapy continues to be helpful for most patients with lung cancer. It hasn't gone away. There's also immunotherapy that is the newest wave that's come in, and that is a treatment that is given to stimulate the immune system to better recognize and attack the cancer. The third is a targeted therapy. Now, targeted therapies have been around for about 10 to 15 years. That was really the first of these in lung cancer was called epidermal growth factor receptor inhibitors, or EGFR inhibitors. And they have continued to be introduced and refined, and they remain a very important part of our treatment, at least for patients with a specific mutation in that target, EGFR. There are other uncommon mutations. One's called an ALK rearrangement, another ROS1 rearrangement, and there's others beyond that. Those are small populations, 1%, 2%, 4%. EGFR is the biggest of the targeted populations. That's about 10% of the patient population with lung cancer in North America. In Asia, it's 3 times that for reasons we really don't understand, but there is a genetic association. It's important to know that these driver mutations are more commonly seen in patients with little or no smoking history. But what's really critical to know is that these driver mutations are like an Achilles heel if you find them, because they have a paired targeted therapy option that you can go after and really hone in on that mutation without as much collateral damage as chemotherapy. Chemotherapy is kind of like a cluster bomb, and targeted therapy is more of a smart bomb approach. It really does much less damage to normal cells of the body, which means fewer side effects in general. Now, it's not to say that targeted therapies don't have side effects or can't have side effects, but they tend to be more precise and better tolerated, which is very good because these are therapies that also, happily, often work for many months to years at a time. And they're more commonly oral therapies. There are some that are IV, but most are oral. And so we go from a historical perspective of treating lung cancer with IV therapy that has traditionally been thought of as toxic and very difficult, to targeted therapies that are often a daily pill that is well tolerated by most patients and able to be taken for many, many months, a year, even many years. It just changes the whole complexion of what you're doing. It turns lung cancer from advanced lung cancer from something that we were limited to thinking in terms of months to now thinking in terms of years very often. It allows patients to be living their lives more because they're just doing oral treatments and often can go for months at a time, or at least many weeks between visits, and not having to have hair loss or other side effects that are a daily reminder of their cancer. So it's literally been a game changer. It's been a dramatic improvement for our patients. It's made many of them benefit in terms of living for years, normal lives with their families without being tethered to an infusion chair. And importantly, we still continue to find new targeted therapies. It may be more options as a first treatment that are more powerful. It may be better control of disease that's been hard to cover in the past, like getting into the brain. It may be chasing new targets that emerge in what we call acquired resistance. Once the cancer has figured out a way around the first treatment, it may evolve a new mutation that we can now come after with another therapy. Now, osimertinib, or Tagrisso, was the first as a second-line therapy. We will now be looking at and trying to find treatments for the new mutations that emerge after that. So it's an ever-evolving cat and mouse game, but it only leads to new and better options for our patients.